Welcome, everyone. We'll give everyone a minute to join. Good afternoon, good morning, good evening to everyone. We welcome you, particularly those of you joining from far away or at late or early times. Thank you for joining this WHO EPI-WIN webinar on empowering community health workers through capacity strengthening for outbreak detection and response, lessons from the field. I'm Supriya Besbara. I lead on EPI-WIN. For those of you who are new to EPI-WIN, this stands for the WHO Information Network for Epidemics for Science and Knowledge Translation in health emergencies. Our goal is to translate science and knowledge and make it accessible, understandable, and relevant for evidence-informed actions and decisions in health emergencies. Today, we have some great speakers who will share with you how community health workers are being empowered through a new capacity strengthening program to respond to outbreak detection and response. Unfortunately, Dr. Nedret Emiroglu, director, could not join us due to unavoidable reasons, but Dr. Kai von Harbu, Unit Head of Community Protection, will deliver the opening remarks on her behalf. Dr. Kai von Harbu will then also talk about community protection and the role of community health workers. After that, Dr. Rim Kwang will give you an overview of the Integrated Community Health Workers Training Initiative, and Dr. Claire Baintoon, a valued partner from UK Public Health Rapid Support Team, will provide the partner's perspective and the global perspective. Then we have the panel discussion. We have perspectives from Mpox in DRC and Ebola in Uganda. We're honored to have Dr. Atim Danson of the Ministry of Health Uganda, who will provide the Uganda experience, and also honored to have Dr. Pierrette Enna, who will talk about the DRC experience. We will then hear from the community health worker directly. We're also very honored to have Dr. Edith Nagula, who's a community health worker in Uganda, who will talk about her experience and how she sees the impact of this on the locality. And finally, how does it affect globally? So we have Dr. Ruben Samuel from the WHO Southeast Asia region, who will speak about how other regions can roll out similar programs. Some housekeeping. This webinar is currently being live streamed on the EPI-WIN YouTube channel. The webinar is being recorded, and afterwards, the recording will be available from our website. The address will appear in the chat. As all of you who followed EPI-WIN regularly know, we love to hear from you, so do post your name, your location, organization in the chat box. And if you have if you want to share your insights and experiences, please share it in the chat box, but please keep all comments respectful, constructive, positive, and relevant to the topic. If you have questions, though, questions and answers, please put your questions for the speakers in the Q&A box. That will enable us to track it more easily and respond to them more easily. Now, before we start the technical session, we'd like to hear from you. So, here we are. I don't know if you can see my screen. We have, please go to slido.com, hashtag 2112407. That's hashtag 2112407, slido.com. And let us know what you think are important for capacity strengthening of community health workers in outbreak detection and response. Please write the first words that come to your mind. We just want to have a quick snapshot of what you're thinking. Engagement, capacity. Communication, training is the word that comes. Listening. Trust. Trust is another big word that comes. Awareness, effective communication. So the different recognition, digital tools, awareness, effective communication. Great to know. And you will hear more about what was actually done. And this is also very interesting and useful to know what you think. So I will leave this on for now, but I'm not going to share my screen anymore. Please continue to provide your feedback at slido.com, hashtag 2112407. That's slido.com, hashtag 2112407. I now invite Dr. Kai von Harbu to provide the welcome remarks on behalf of Dr. Nedret Emiroglu. Over to you, Kai. The floor is yours.
Yeah, thank you very much, Supriya, and good afternoon, everyone. My name is Kai von Harbu. I lead the Community Protection and Resilience Unit here at WHO headquarters. First of all, thank you to all of you for joining us today, and apologies from our director, Dr. Nedret Emiroglu, who was called for an urgent meeting and won't be able to attend this meeting. But she asked me to open this meeting on her behalf and really express her deep appreciation for all the speakers and all the participants to join this very important discussion today. And as many of you know, we have a new framework at WHO outlining our work around emergency preparedness, response, and resilience called the HEPA framework. And community protection is one of the 5 core subsystems of this framework. And this really reflects a shift in how we think about health emergencies, placing communities and their capacities and their leadership at the center of all our efforts around preparedness and response. And we really think here at WHO that this shift is even more important in the current context we're working in today. I think we are all aware we're seeing a growing number of countries that face multiple overlapping emergencies, outbreaks, conflicts, climate-related disasters, often happening at once. And today in the webinar, we will hear from 2 such countries that are navigating multiple emergencies simultaneously. And we will hear how integrated and community-centered approaches can help to manage these really complex realities. And at the same time, we all are aware of the situation around our global funding under pressure. And in this context, investing in early detection and response at the community level, supporting local solutions, supporting resilience building, all of this offers the highest return of investment, and it prevents escalation of emergencies. It reduces the need for top-down interventions, and it fosters long-term self-reliance. This is why we think these are just two aspects. Many others were mentioned also in the questionnaire earlier in the responses around trust building, etc. All of these aspects make it so important to have a community-centered approach. And this is why it's so timely that we have this webinar today. And when we talk about strengthening community protection, we are really talking about investing systematically in community actors. And at the forefront of these are, of course, community health workers. And this is what we'll focus on today. Community health workers are the critical enablers of community protection. In many countries, they are the essential link between the health system and the communities and the people they serve. They are trusted communicators. They are frontline service providers, and they are really vital components of early warning systems in many, many countries. And most of the time, they are the first responders to any health emergencies. And this is why we want to focus so much on this community workforce when strengthening community protection. But for community health workers to be effective, they need to be coordinated, trained, supervised, equipped, and supported systematically, and not just during emergencies, but as part of a sustained system of care and preparedness. And these are many aspects that we'll talk a bit more today. We will hear from our colleagues, Dr. Donsan and Dr. Pierrette from the Ministries of Health of Uganda and DRC on the lessons learned in the integrated capacity building approaches for CHWs during the Mpox and the Sudan virus disease responses that we have underwent together recently. And these are really examples of just-in-time standardized training, enabling community health workers to immediately engage in surveillance, contact tracing, case identification, reporting, etc., all these core functions. And we are also very fortunate to hear directly from one of the participants from one of the trainings, Ms. Edith Naluga. She's a village health team member from Uganda, and it will be really, really critical for us to hear from her experience firsthand, because this is not about the work we are doing here in Geneva. It's not about the work on paper. It's about what works in practice and what community health workers are facing every day on the ground. And their voices are really critical. It's really important for us that we make their voices heard on identifying gaps and also in shaping effective community-driven solutions. We're really advocating for the community engagement in decision-making, and that was also one aspect that was highlighted in the questionnaire earlier today from one of the participants. And then we also hear from our key partner in this space, the UK Public Health Rapid Support Team. And it's really great to have Dr. Claire Bainton with us, who is the head of the capacity building at UK HSA. And she played a really vital role in advancing with us in this space. And then we have a very, very important colleague from the regional level, Dr. Ruben Samuel, who is the program area manager at WHO's Southeast Asia Regional Office. And he will share with us the approaches that CRO is taking around community protection and strengthening community health workers, but also a very important aspect, how can this be integrated into global investment mechanisms like the pandemic fund? Because I think this is a crucial step forward. We have to look at the sustainable funding of these approaches, because it's really important that we have this as a response mechanism, but we also want to move away from the ad hoc reactive training, and we want to go into institutionalized competency-based learning and proactive system building of community health worker mechanisms. And for that, we are working on a competency framework, a structured curriculum to really support that shift and align with the broader health system strengthening. And many of you joined our Learning for Impact webinar series, where we have already started the work on building those approaches as well. And what all of this reflects is a very, very important and clear message. Community health workers are not a temporary asset for emergencies. They are our long-term partners, both in health security and in emergency preparedness, but also in resilience and at all the different levels. And this is what we at WHO are committed to. We want to ensure that community health workers are trained, trusted, equipped, and most importantly, heard. And this is an important opportunity for this, but we will also move this forward, for example, at a side event at the World Health Assembly that we are hosting together with IFRC and UNICEF, who are very important partners for us in the area of community protection, in just a few weeks. And we will share some information on that with you as well. This is a really, really important aspect where we also talk about the central role of community health workers in emergencies. But for now, I'm really looking forward to the presentations and the discussions today. Thank you again for being with us to presenters and participants. And back to you, Supriya.
Thanks very much, Kai. So now I hand the floor over to Dr. Rim. Rim will provide the overview of the new training initiative. Over to you, Rim.
Yeah, thank you very much, Supriya. By the way, can you hear me?
Yes, we can hear you. Great, thank you.
Okay. Hello, everyone. And my name is Gwang-il Lim. I'm from Community Protection Resilience Unit, same unit with where Kai is leading. And for me, it's a great pleasure to have this opportunity to share our experience of empowering community health workers through integrated initiative now being implemented in the countries together with our panel members today. And training program for community health workers are not new. There are many ongoing initiatives and programs in the various countries and also by partners. So our initiative is one of them, but it is a bit innovative in a way that integrate key community-based public health function under 6 or 7 modules, depending on hazard we are taking and also need at the country level, given the roles and functions of community health workers during the health emergency response, which Kai already highlighted. This is part of also operationalization of community protection of HEPA framework, which Kai just have explained. My presentation will be short, 10 minutes, just focusing on bigger picture, providing an overview of our training package structure, outline, and also main content of key module, and also a bit on training methodology, and also some of the important learning points from each implementation at the country level. And finally, some consideration for way forward. Since our webinar will be just 1 hour, so we may not have enough time to get into details. Therefore, we aim to kind of use this opportunity to introduce our main program structure and also hope to collaborate more in the future through our WHO regional and country offices, as well as other partners. Next, please. Next slide, please. Kai already highlighted the central role of community health workers in health emergencies. Key point from this slide is to recognize the essential functions and tasks that community health workers perform in the health emergency cycles. These include detection, notification, and also community level response operation, and also community level health service delivery, which include also timely referrals. In fact, community health workers are the first responders and community level service providers, reaching out to population in vulnerable population situations and including inaccessible areas. They connect communities with primary healthcare centers, local surveillance system, and also rapid response team to respond to health emergencies, as well as protect people in their communities. Next, please. WHO is actively working to operationalize this concept of community post-protection in various countries by applying a community-centered and participatory approach. This approach aims to bring community members and also community health workers together with health professionals and also authorities at the primary healthcare level and also district and national level. Our first activity in that regard took place in Ghana in January last year in collaboration with MOH Ghana and also WHO 3 level, and also UK Public Health Rapid Support Team. During this activity, community health workers and volunteers, and also community representatives from 3 communities in eastern part of Ghana attended as important participants. Key recommendation from this workshop was to training program to train community health workers and volunteers in early outbreak detection and response, combining community-based surveillance, risk communication, and community engagement, and also coordinate at the community level, and also include one aspect at the community level. Next, please. The insight gained from this Ghana workshop enabled us to initiate the development of an integrated modular training program for community health workers. Our approach to designing this training program was initially focusing on the Ghana context, particularly learning from the existing health system and community structure, which you can see right side of this slide. We examined how health emergency management functions connect with those structures from the community level to sub-district level and district level, and then to regional and national level as well. We aim to identify functions and tasks that the community health workers and volunteers are already performing as mapped in the district level health emergency preparedness and response plan of Ghana. So understanding the country structure and functional alignment of health workforce within the existing framework is crucial for developing such a capacity building program that aligns with these structures and functions. Community health workers are positioned between the health system and communities, playing a crucial bridging role to connect these two parts. They are already involved in community-based health programs such as community-based surveillance, health promotion, water sanitation, hygiene, and first aid, and more. Next, please. Based on this insight gained, we have designed modular training program that covers key technical areas such as early detection, alert and contact tracing, risk communication and community engagement, infection prevention control, and WASH in community settings, mental and psychosocial support, and also community coordination, as you can see from this slide. We successfully piloted this training package in November last year to support one community center in Kinshasa, the Democratic Republic of Congo, in responding to Mpox. Additionally, we conducted a training workshop for national trainers in Democratic Republic of Congo in January this year to strengthen national capacity to roll out community health worker training across the provinces and health zones in the country with a clearly defined implementation plan and also resource mobilization strategy. Next, please. Our main approach for rolling out this community health worker training is 3 levels. First, collaboration with national team. We begin by working very closely with national team through online to review country context and structure, existing training materials, and also profiles of community health workers and volunteers. This helped us adapt the global training package to fit the specific country context. Then we organized a national training of trainer workshop to ensure that this initiative is nationally led and also has a clear implementation plan. This workshop equips national trainers with necessary skills and knowledge to deliver this training program in their communities effectively. Then support for rolling out the training program. We support national trainers trained through this TOT in rolling out a training program at a community level. This includes providing operational plan, also resources. Our role is to offer support when requested, ensuring that training is implemented smoothly and effectively. Next slide, please. We have basically 7 or 8 modules that can be adjusted depending on the disease that training is going to cover, and also based on the country context and situation. So training materials we have developed so far very interactive and emphasizing more simplification of the content by adding more visuals and also simple diagrams and pictures, as you can see from this slide. We also conduct role plays, scenario-based activities tailored to our audience's need. We also use adult learning methods and technique to ensure that training is engaging and effective. Next, please. While implementing these trainings, there are important learnings that we learn and also we want to share. First, our key approach to support Ministry of Health as WHO to train national trainers through TOT workshop to build national community health worker training program with country ownership and also ensure sustainability of this type of activity. Then during the TOT workshop, we supported to develop implementation plans so that national trainers can roll out community level training with clear operational plan, and also coordination mechanism, and also monitoring and evaluation plan, importantly, resource mobilization part. Another aspect is participatory approach and co-development of training material together with national experts and professionals, ensuring relevance and acceptance. This participatory approach and co-development process enables you to adapt training materials developed globally to fit the specific context and needs of each country. We also try to ensure that training initiatives are led by national facilitators to promote local ownership and leadership. We received good feedback from countries and partners that this training package is operational and practical and relevant. In the whole process of development and implementation, we ensured joint work between national and international facilitators, including our partners like UK Public Rapid Response Team, to leverage diverse expertise and perspectives. Next, please. This is my last slide, and I would like to emphasize some of the way forward consideration. So as Kai already mentioned, that based on our learning and experience, we are now working on competency framework for community health workers in health emergency management context. WHO Health Workforce team is in the final stage of competencies for community health workers for all health program areas. We are adapting it into our health emergency context. Also, we are working on finalizing generic training package or curriculum plan for all hazard, which can be adapted for specific hazard and context, as we did for Mpox in DRC and also Ebola in Uganda. Now we have package for Mpox and Ebola and plan to work other priority hazards such as cholera, natural disaster, and also pandemic response. We are also ready to provide tailored support to countries for implementation of the training programs. Ultimately, key aspect is to integrate community health workforce for health emergency into national health workforce strengthening initiatives and programs through supportive policies and programs and investments. Another important aspect is to promote collaboration across various sectors, including animal health, environmental health, and social sectors. So expanding the scope of this training to cover other aspects, which is covering one aspect. I think these are my presentation, and happy to take any question. Over to you, Priya. Thank you so much.
Thank you so much, Rim. Thank you very much. I'd like to now invite Dr. Claire Bantoon to please provide her perspective of the training initiatives for community health workers. Over to you, Claire.
Thank you, Supriya. Thank you, Rim. And it is such a pleasure to see in the chat from the audience everywhere that you are joining from. Thank you for putting the time into putting your messages there. It's a delight to see. And also it's a real pleasure to be reunited with some of the colleagues that we have delivered in the countries that we've been working with. So first is to recognise what we're talking about here is the strengths, the assets, and indeed the experts of communities. That's why community protection is so important for how we manage outbreaks. And indeed, as Rim has alluded to, we are stretching this to look at other wider all hazards. So my name is Claire Bainton. I am a consultant in global public health with a medical background, and I am head of the UK Public Health Rapid Support Team's capacity strengthening pillar. We have worked as my team hand in hand with RIM's team, and we have worked with them on all of the capacity strengthening activities that RIM has kindly outlined today. The Rapid Support Team, we're a collaboration between the London School of Hygiene and Tropical Medicine and the UK Health Security Agency, which is the National Public Health Institute for the UK. We are funded by the UK government to deliver the work that we do, which is outbreak management in low-resourced countries. We have three pillars. One is deployment to go work and support in outbreak management where and when we're invited to do so. Research, which we do with partners from those countries with whom we work, and capacity strengthening. In terms of our capacity strengthening activities, we've delivered 100 activities in the last financial year, which is a great achievement with this pillar having really flourished with with the opportunities to support. And just to highlight that we have in our team expertise in epidemiology, microbiology, infection prevention control, risk communication, community engagement, social sciences, mental health, psychosocial support, education, and wider public health leadership. So I'm going to touch on the why, the what we do, the why we're doing it, and the how we're doing it before just looking at some of the future opportunities. So what is it we're doing here, working with our colleagues as a global partnership? So the range of activities that we do is to be delivered across all levels. We aim to equip community health workers with the skills and the tools that they need to detect cases and respond to outbreaks. And we want to be able to advocate for community protection approaches with and through these communities, but importantly, also doing that at district levels, national levels, regionally, and on the global stage. So why is RST doing this? We recognise that communities are self-motivated for resilience. It's in our human nature. When there is a challenge, communities come together. However, we have also learned that without the tools and without building them into the infrastructure of response, that resilience is more limited, and we want to push that to a different context going forwards. So we noticed this, that although involving the community has been discussed in documents for at least the last 3 decades, in actual fact, their perspective has often been neglected in reality. And proof of this can be seen from the COVID pandemic, where response was largely centrally led, or if it was decentralized, it was still done to communities rather than with the communities taking the empowered leadership of their response. So while communities will self-mobilize, it's really important that we integrate them formally into the response structures. And this is something that can be managed and is needed across all cultures. So what is the opportunity here for taking forward the community protection approach? You're going to get a more rapid initial response, so earlier detection. We're going to get more effective responses because you get the buy-in and, of course, the trust from the community members, which is where it matters most. And we get more effective and more contextually relevant and appropriate response. So what's the how? So initially we were involved as consultants with HQ on community protection, development of guidelines, checklists, frameworks, and so on. But we felt that it was really important that we advocate to road testing this in member states and on the ground with communities. We have done this working through colleagues at regional level, fantastic support from WHO AFRO, for example. Then with country offices, ministries of health, national public health institutes, and relevant partners within those countries, and importantly, with the community health workers themselves, thus strengthening the response infrastructure right from the bottom, right up to the top. So we have a role on the global stage as a global partner in this for advocating and embedding community-centered policies, strategies, and practices. So what does RST specifically bring to this partnership? RST has considerable experience of working on the ground in outbreak contexts. So we are bringing that lived experience, if you like. We are also able to bring the technical experience for a range of different pathogens and how that plays out in terms of a response in different contexts so that we can identify, right, what are the gaps, what are the priorities, what are the challenges that can be faced. And we do that then obviously working with specific countries and their communities to tell us more about what that means. But we're coming with that sense of knowledge of what it is, what those challenges are, having been there ourselves. It also, RST, my team brings adult learning and education design expertise. And when we're designing this work, the work that Rim has kindly outlined, we're talking about how in the moment of the training, those communities can identify and map what are their current resources, what are their current challenges, what are their needs. So what is really the important way forward with this work? I just want to highlight a couple of future recommendations. Capacity strengthening, the tools, the resources that we've done, that is just the first step. What is really needed and what is the main challenge is to sustain this learning and to sustain its implementation across communities and across countries. At the national level, that means ministries of health embracing this idea of community protection so that it is fit for purpose for the long term and that community health workers have a clear functional role that is properly resourced. On another level, the regional level, the priority is that they let us know where it is that we should be working. So where there are particular outbreaks that are going to be expected or are in play, where our support with working with community health workers with this type of package of community protection is needed, but also countries that might have pandemic funding, for example, and thus can support the rollout of these activities as we go forward. So I'm just going to wrap up now just to, again, thank you all for your participation in this webinar and to highlight the very fantastic partnership that we have working with WHO HQ, but also with our colleagues when we work with AFRO and country offices and with ministries of health, and then importantly, colleagues such as Edith, who's going to be speaking later, when we actually are on the ground working with community health workers. That is the real pleasure of this work, and I'm very excited to hear more from those individuals as we go through this webinar. Thank you. Back to you, Supriya.
Thank you very much, Claire. Can you hear me?
Yes, I can.
Yeah, okay, great.
Thank you.
Thanks for that overview and very interesting to get the background of everything that's happened. Now we go on to our panel discussion, and I'd like to invite Dr. Atim Danson, Dr. Pierrette, Miss Edith Nagula, and Ruben Samuel for a discussion on this and to get the country and regional perspectives. Host, could you please enable my camera? I don't think my camera is working. So my first question is to Dr. Atim Danson, who's from the Ministry of Health in Uganda. Dr. Danson, having done this training, how valuable do you think an integrated approach is in leveraging community structures and workforce, such as village health teams, and in building their capacities for health emergencies like the Ebola outbreak?
Thank you so much, Tim. I'm called Dr. Tim Danson. I am the community-based surveillance head for the country. I have a background in human medicine and in epidemiology. The question is very clear: how valuable is the community-based surveillance? Yes, this is a very valuable training that we have had as a country. By the time we had the training, there was an outbreak of Ebola, which was running for mpox. So we actually benefited so much from this training because we were able to contain the Ebola outbreak. We leverage on that. I don't know whether I can go on to presentation with my slides, or I can first answer the questions, then we...
Please go ahead with your presentation, that's fine.
Okay, thank you. So thank you so much. I'm Dr. Danson. As I've said, I'm the community-based surveillance head for Uganda and the SAPILA head for this outbreak responses. As a country, we had the training for community-based surveillance in February. During that time, we had running outbreak for Ebola. That was already declared on the 30th of January 2025. And then the one for mpox, which was declared in 2024, July. So by the time we had the training in Uganda, Uganda was already declared having Ebola and then mpox. Although at the moment we through the support and the training, we are able to contain the Ebola Sudan outbreak within the 86 days. Then as a country, we are still grappling with the outbreak for Mpox. So as a country, we were able to identify the roles of community-based surveillance with that support. And the outbreak, we were able to have detection of Mpox by screening using the community-based surveillance, which we have them. As a country, we had worked on the community definition. And we were also able to orient our community-based surveillance team, the community members, on how to notify and report these alerts to the national team, but also to the sub-national team using phone calls. And then we have a system that works for us, which is 6767. This is an electronic system. Then we were able to have the community support in the response by having community mobilizations and referrals. And then they supported us in community dialogue and contact tracing. So if you could see from the picture there, we have a community worker, Edith herself, screening a security agent. So with the support, with that training, we were able to orient our communities by conducting home visits to households which were at high risk for Ebola, but also with the Mpox. The picture on the left is the community workers moving to household to sensitize the community and the household. Then this picture is for another community health workers sensitizing the members. We have got the health workers with the community moving to supervise and support the community team. So community-based surveillance contributed to Ebola outbreak response and containing by supporting other sub-pillars like the alert management. Through the community, we were able to raise signals and then alerts and do contact tracing and contact follow-up. So they actually supported the health workers to identify the homes which were at risk, and then supporting the risk communication and community engagement pillar on integrated response and community sensitizations. So we also are using the community-based approach that we gained from WHO. We were able to support the school-based surveillance. So if you could look from the Ebola response that we had, the community alone generated a cumulative 1,124 signals, of which 1,094 were able to be alerts that were actually having positive signs of Ebola. So the lessons that we learned from this Ebola outbreak from the community-based surveillance through the training that we have to respect having the respect for cultural and religious diversity is actually key. And we realize that it actually reduces on community resistance and conflict. When we had this outbreak, there was a group of a cluster of outbreak that had occurred within the Muslim community. And we were able to diversified religious norms, and they were monitored from their homes for 21 days using support from the community health teams. But also we realized that the zoonotic disease outbreak need one health approach. During that outbreak that we declared Uganda free on the 26th of this month, we were able to deploy teams from the environmental and animal health. So that actually gave us a great milestone in containing Ebola outbreak, Sudan Ebola outbreak in Uganda. Then the capacity building for the team that we had for the districts that WHO had supported us in February, we were able to deploy the team that were trained to support the response in the districts that we identified Ebola in. And the second last was we integrated response that actually improved our responsibility. We had the presence of anthropologists and then the risk communication specialists that work with the community to support the response. Of course, the last one was digitizing of community reporting tools that actually enhance us to have timely reporting in the alert management. So as I said, we still have outbreak of Mpox in the country. And the question that we have is, can the lessons that we learned from Ebola Sudan community engagement and community-based surveillance help us to contain Ebola Mpox outbreak? And it is a yes, because so far we have already done an involvement of community health workers to convey targeted risk communication. If you can look from the picture down, we have got what we refer in Uganda as sex workers. They are being supported by having targeted risk communication that is being done by the community health worker. But also we have collaboration, and we have involved the community leaders in creating and disseminating informations. And some of these information are actually being bought by the community. And also we have distributed the IEC materials to hotspot areas with the support from the community. And orientation of communities and schools using the community. The challenge currently we have could be on issue of One Health that sustain the mpox in the country, and if we can really strengthen our One Health approach, then we will be able to clear with the mpox outbreak in the country. Then, of course, the last one is having an involve home-based care, involving the community in the home-based care, which currently, as a country, we still have a challenge on that as one of the key things. And of course, the recommendation that we have, which through WHO, is that if we can develop and orient and disseminate guidelines for home-based care. Thank you so much for listening to me. Over to you, Rim, and then yes.
Thank you so much, Dr. Atim, for that very comprehensive overview and for highlighting both the successes and the lessons learned and the challenges, such as involving community health workers for mpox, providing guidelines and all of that. Now, we would like to hear directly from a community health worker herself. We have with us Dr. Edith Nagula. Miss Edith Nagula. So, you work with village health teams. We'd like to hear from you. What impact has the community health worker training had in your locality? And how would you advise the Ministry of Health and the World Health Organization to adopt a localized approach to capacity building for community health workers? Over to Edith Nagula.
Thank you so much, Supriya. I'm so glad to be part of this platform. I'm so delighted, and I really appreciate for the opportunity to say something. Am I clear? Do you get me?
Yes, we can hear you very well, and it's great to have you here.
Thank you so much, Ms. Priya, and the entire WHO and UK Health. Good afternoon, dear friends, colleagues. It is exactly 2:49. It is 11 minutes to 3, so it is afternoon. Right away, I would like to go to how the impact that the training, the impact that it has posed in my region and also nationally. And yeah, thank you so much. So following the training of community health workers, we had it in Entebbe in early Feb. That was around 4th to 6th. It was a 3 days training of community health workers under the community protection approach, prepared to detect potential health threats such as Ebola, mpox, and so many other diseases of public health importance at the earliest opportunity in our communities. So that training, it has enabled me to promptly notify authorities and rapid response, which is crucial for containing outbreaks before they escalate. Otherwise, we would have a very widespread spread of diseases. Like Ebola, thankfully, we've been declared Ebola-free in the on 26th, just last weekend. And so you realize that this training actually aligns with the WHO's health emergency preparedness response and resilience framework, because it emphasizes that Health emergencies begin and end in the community. That is one of the strongest phrases that I picked from that training. So after that training, I have participated in both local and national level trainings with MOH and partners. There are so many partners that have supported Ministry of Health to see that community-based surveillance moves places. So I really thank the Ministry of Health for picking on this community-based surveillance and escalating to, pushing it to all the regions, in this country. I have personally, through the training that we had in Entebbe earlier this year, I have been able to participate and train a number of health workers. I'm going to break them down: community health workers, VHTs, security personnel, border agencies, and opinion leaders, to improve their understanding of epidemic and pandemic management, including the recognition of signs and symptoms, effective risk communication, mortality surveillance, basic infection prevention and control protocols, and also accurate reporting. Because you realize accurate reporting, it's been, well, there have been reporting systems, but when you try to see the impact that, community health workers interface with these conditions in the communities, but they haven't been reporting effectively to the national level, so that they are captured through the surveillance systems. So these are some of the training that I have that I've been honored to participate in. There was immediately a training supported by IOM. It was a 3 days training. We were training border agencies because, as you realize, that time we had just had a declaration of an Ebola outbreak. So we were Minister of Health was trying to strengthen all ports of entry and screening at ports of entry. So the very first engagement was actually under IOM for strengthening ports of entry. So from that training, it was in Bukwa. It is a border district with Kenya, or in the far east. Yes, in the far east. So we trained 100 VHTs. The same month, we went to Goli port of entry. It was still under IOM, it's supported by IOM under the Ministry of Health. It is also a border point. It is bordering Congo and Uganda. We also trained 100 VHTs. So you realize my expertise, I've had an opportunity to share all this knowledge from the CBS and HARP training in Entebbe. Not that that's just not it. In Moroto is somewhere in Kapchora, the Karamojong region. Okay, we trained 70 VHTs. That was under Uganda Virus Research Institute. That was the supporting partner. And then, I've had an opportunity to train over 500 VHTs, including those in Wakiso district. So back home here in Wakiso district, in Entebbe itself, we've just had a training. It is about 2 weeks ago. We've trained 100 VHTs, 50 VHTs in Entebbe, and then 50 VHTs in Nansana. These were targeted trainings because Entebbe training focused on VHTs coming from Kasanje. There were 2 Ebola cases in Kasanje, so we needed to scale up a lot of training and also capacity building for the VHTs from those affected areas. And also Nansana, also we targeted 50 VHTs under Africa CDC, supporting implementing partner. We targeted VHTs from Watuba. There is a photo there. Actually, the index case was partly staying in Watuba. If I remember very well, yes, the index case stays in Watuba. And so we had to do a lot of capacity building for VHTs coming from that side and neighboring divisions. And also yesterday itself, we had a training and supported by Baylor, Uganda. We supported 40 VHTs from Nabweru, and we could see that some good number of VHTs that have actually whose lives and whose knowledge I have been able to at least have a building stone, And then locally, we have had so many engagements following that training. It was, I really appreciate WHO because that training came at a time that we really needed it most as a country. And as Wakiso district, I should say, because Wakiso district gets hit by outbreaks, almost the worst, second to Kampala. So you realize that a lot of capacity building is very important in and around Wakiso district. So locally, in my division here, I come from Nasana division, sorry. So with support from, there is a community-based organization here. It's called Safe Circles. We have been able to implement a lot of community-based surveillance activities. We have so far moved to 61 schools. We have so many schools in Nasana division. We have moved to 61 schools. We have sensitized 10 markets. I have a whole album of pictorials. I would like to share upon request. And we have sensitized border stages, at least 30 of them. Border, if I may explain a little bit, border is motorcycle, okay, motorcycle stages. It is one of the, border transport is one of the fastest and the kind of public transport you won't miss when you come in and around Kampala. So we have also moved to 15 places of worship, 3 taxi parks, and at least 451 homesteads have been visited by the community health workers as of yesterday. We have really achieved a lot as a division, as a district, and as a country, because all this data, it contributes to the bigger picture. So community-based surveillance has played a pivotal role in mobilizing key populations for the just concluded Mpox vaccination. Otherwise, without community-based workers, we wouldn't be able to hit and reach all these vaccination targets as prior planned. So for Nasana division alone, with the strength of our community health workers, because how we mobilized them to make sure that they become they become key persons in this kind of mobilization is community health workers know the communities best, and you just cannot hold a successful community event, a community activity without engaging them at all. So as a district, we were able to vaccinate. We had a target of vaccinating 9,000 key populations. Okay. So Nasana division alone, we vaccinated 3,902. That is about 3/4 of the entire district. And Wakiso is a very big district. So Nasana alone contributing this huge figure to the vaccination. I call it a success. And then the other achievement that we were able to achieve through community-based surveillance is now that VHTs are reporting, they're reporting greater confidence in delivering health education. They are promoting preventive measures and managing, cases, and, they are so dedicated, and they are so dedicated to performing, because I'll give an example. Maybe someone may ask why this time the dedication and not before. So you realize that before, our community health workers were focusing on the children 5 years and below, the under 5s, and also expectant mothers. So when we came up with, when we introduced community-based surveillance, it fits exactly into the roles that they have been playing in the community. They carry out community visits, they do school visits, and so on and so forth. So we just introduced community-based surveillance so that this time around, when they go to conduct their home visits and their routine community activities, they are not only focusing on the well-being of the under 5 child and maybe only the expectant mother. They're also focusing on the well-being of everybody in the household, and thus the whole essence of community community-based surveillance.
Sorry, Edith, sorry to interrupt. Just in the interest of time, it's really wonderful to hear from you, but could you please wrap up a little bit? Thank you.
Yes. Thank you so much. Just a minute or two. I'm just finishing up with the achievement. I'm delighted to see this achievement coming in. So the other achievement that we have noticed is that now VHTs or community health workers have started reporting through that system, through that electronic system, the 6767 alert. Before, they never used to do that. I'm sure now that even when the Ministry of Health tries to run a database, they'll be able to realize that VHTs are actually reporting and also contributing hugely to the surveillance pillar. I really thank you so much, Priya, for the opportunity. And I highly recommend that community-based surveillance is the way to go in strengthening communities to detect diseases at the earliest onset in the communities. Thank you so much, Madam Priya. Over to you.
Edith Nagula, it's wonderful to hear from the community perspective. And I wish this webinar was, we had much more time so we could hear more at length from you, especially on the achievements on the ground. In fact, we're also happy because we've, in the chat as well, the participants are sharing their points of view. There's someone from Ghana, William, who spoke about a community based volunteers work and how that's made a difference. So great to hear from participants responding to what you've said, Edith. But we've actually, although we've run out of time, I request all participants, if possible, to please stay on because we have, very interesting perspectives. We have 2 more speakers. Edith, Dr. Pierrette from DRC will now give us a different perspective from DRC. Is she online? I know there were some tech issues there. Dr. Pierrette? If not, we will then go on to Dr. Ruben Samuel, who will talk about, who we would like to request him to talk about how regions and countries. Dr. Ruben Samuel is from the Southeast Asia Regional Office for WHO. So, we've heard about Uganda, and we've heard about the training program in Africa, but how can such programs be rolled out in other regions and countries? How can the capacity building of community health workers be integrated into national policies and programs to enhance pandemic preparedness? So over to you, Ruben.
Are you able to see my screen, Supriya?
Yes, we can see your screen. Thank you.
Okay, thank you very much. So I think it's indeed a pleasure to be part of this panel of different colleagues from different parts of the globe, and also with our headquarters colleagues and the UK Health Agency, who have been able to lay out the overall intent of this particular initiative, which has been rolled out globally, but the interventions piloted at the most local level. So I want to really look at from the regional perspective how we are approaching this, and I'm trying to advance my slides. So in the Southeast Asia, region, the countries have long been using multiple types of community health workers and community volunteers, groups, networks, etc., for various types of public health action. And there are a variety of such community health workers. Some of them are paid workers at the most local level, who are the interfaces between the formal health system and the community, mandated to provide services. But there are also a large number of community health workers who are not employees as such, but rather they do certain services for which they get paid, or for the services that they deliver in terms of certain incentives. And there are also other workers who might not even get a kind of a fee per service, but rather they are provided certain incentives, such as medicines, maybe some implements for reporting and things like that, etc. And there are pure volunteers. So there's a variety of people who are currently performing this type of initiatives at the community level. So in terms of the challenges, is my slide still showing, or yeah? Next slide. So there are the challenges are that, as I mentioned, there are multiple disconnected workforces, and they are not just limited only to the health sector, but they are also in the other sectors, especially the social welfare, women and child development, and such initiatives and sectors. Mostly they are under-resourced, and as I mentioned, that some of them might not be paid. And so if we are going to mobilize such unpaid or partially paid workers and also volunteers, we need to really look at what would incentivize them to really provide these type of services gratis, or with some level of support. And sometimes it might be just recognition at the community level is all they need, especially if they are actually volunteers. And as with many other countries and many other regions, there might be not that much of support and at the leadership level, at the decision-making level. And one other important issue is that in places and in countries where these community workers, quasi-community workers and health volunteers are actually used, there's an over-reliance on them also, and they're already doing a lot of public health functions. And so though it might seem very easy to kind of load them with additional activities, it might not work in certain places, and we need to really look at how we optimize what they are doing while at the same time empower them to do more, and also identify what other opportunities and people are actually available who can actually increase the current workforces or the volunteer forces that are currently there. Next, please. In order to ensure that this happens in a systematic way, and especially learning from the COVID experience, we had, right after the COVID, instituted certain very systematic lessons learned workshop, including in this specific area of risk communication, community engagement, infodemic management, etc. And based on that, we were able to distill regional health security and health system resilience for a roadmap, and which was endorsed by our 11 member states. And following that, in each of these so-called health emergency, preparedness, readiness, response, and resilience pillars, we have been able to develop strategic action frameworks dealing with the specific pillars. And one such strategic action framework has been on the community protection, or we call it as community engagement and resilience. And these have been agreed upon by all our member states. And also it is clearly highlighting certain national level priority areas which require investment, and also certain regional initiatives which need to be done collectively with not just the member states alone, but also various regional associations, UN partners, INGOs, civil society organizations, academia, a range of stakeholders to work along to leverage and also to build upon and catalyze work that is happening at the country level. Next slide, please. And if you notice of the various activities or the priorities for investment that we have identified and countries have acknowledged and endorsed, expanding and empowering community workforces is our second priority among various other priorities. Next, please. And some of the things that we are currently doing is to ensure that standardized capacities and functions are really normatively issued, people are sensitized, made aware of, and they own up to it. And these are integrated into the regular health emergency operations. This actually also reflects on several other interventions made by the previous panelists and also the people who laid the, raised the curtain, and where they clearly said that such activities happen suo moto, and communities actually self-congregate and do various things, but their impact would be limited unless they are actually aligned and integrated into formal systems and operation mechanisms. And they can also perform functions not only at the level of response, but at every part of the health emergency and disaster risk management cycle, starting from risk reduction to prevention, preparedness and readiness, detection and response, and also during the recovery efforts. One way that we are making sure that various activities that they can do in different parts of the health emergency and disaster management cycle is to kind of, clearly articulate and integrate it with the national and subnational risk assessments for both imminent and also emerging public health threats, proximate and predictable, through doing such assessments called STAR, or Strategic Assessment of Risks, which we have also piloted very recently at the community level, at the district level, and we have just completed one which involves a district where there is a huge refugee or displaced population in Cox's Bazar of Bangladesh. So we hope to do such things in other areas as well. Next, please. And we are also, along with various partners and also the member states, trying to lay down a stepwise approach to systematically build the community workforces in terms of their competencies and their capacities themselves. First, doing a situational analysis, then designing the community workers capacity building program. And here we believe that we will not be reinventing the wheel, but we will actually make use of what is already available in the countries, what is already available at the regional level through various other programs which have done such work, especially maternal and child health, communicable disease control programs such as HIV, AIDS, and tuberculosis, immunization program, etc. They have done quite a bit of work in this area, and we can definitely make use of those and also take on the global work that has already been done and highlighted by RIM, etc. Pilot test, and then once we are able to see that these works at the level of the country, in a particular country, according to its context, scale it up in the country and learn from it, and also scale it up in other countries as well. I think next slide is my last slide.
Thank you, Ruben. Yeah, I was going to say it
yeah.
because I'm sorry if we're so over time.
So what are the things that are needed is basically these critical actions in terms of buy-in from the leadership, especially for integrating such work in the health emergency and disaster management frameworks at both at the national level and the subnational level. In both investments to be generated and mobilized, and also allocation of the funding for this particular type of activities, because we all know that health services usually trump community level actions. And even in health services, we know that higher level, tertiary and secondary level facilities get much more resources than primary healthcare. So I think that movement needs to be needed. And even in primary healthcare, rather than a clear orientation on health facilities themselves, to really focus on community work. And we have made a beginning by mobilizing resources through the pandemic fund, and we have 5 successful single country projects currently going on of the 11 countries that we have in our region. And we also have a successful multi-country proposal at the regional level, which involves at least 6 countries, where we are actually initiating such actions along with our key partners, UNICEF and also IFRC. And we hope to expand the scope of these investments, research, resource mobilization, etc., to leverage what is already available at the country level through domestic funding, and also development partners who are present in the country and interested in investing in this area, so that we can go forward with more expanded continuous training and capacity building at scale in each of the countries where this is actually required. So thank you very much.
Thank you very much, Ruben, and apologies for asking you to hurry up, because unfortunately we're well over time. We have all, however, there were some technical issues, but we now have with us Dr. Pierrette from DRC to provide the DRC perspective. Dr. Pierrette, over to you, but just very briefly, because we are very much over time. What are your experiences, very quickly, and lessons, the key experience and lessons learned from implementing community health worker training for the MPOX response?
Oui, merci de la parole accordée. En tout cas, je m'excuse premièrement pour cette connexion limitée. Et effectivement, nous sommes vraiment près des communautés, dans les endroits reculés, avec un accès à Internet limité. Mais concernant l'impact de la formation des agents de la santé communautaire appuyée par l'OMS à Kinshasa, aussi la formation des formateurs aussi, qui a été faite selon l'approche Une Santé. Je peux vous dire que le renforcement des capacités des acteurs a permis de renforcer la surveillance à base communautaire dans le cadre de la réponse MPOX, mais aussi elle a permis d'améliorer la communication du risque et l'engagement communautaire dans les communautés par l'adhésion des mesures de santé publique par cette communauté. Ici, par exemple, je vous parle de l'amélioration de la recherche active des cas suspects MPOX à travers la définition communautaire de la maladie. Les agents de santé communautaire, par les connaissances acquises, ont pu maîtriser les signes de la maladie, et ça a permis de renforcer la recherche active au sein de la communauté. Non seulement ça, ça a permis aussi une notification rapide des cas suspects auprès des autorités sanitaires. Nous avons pu enregistrer 15 à 50 alertes par jour après ces renforcements des capacités. Les listages et le suivi des contacts a été amélioré avec ce renforcement des capacités. Sans parler de la vaccination contre la Mpox qui a été un succès, on a noté un engouement de la communauté face à la vaccination contre la Mpox. Donc, grâce au renforcement des capacités des agents de santé communautaires qui ont joué un rôle essentiel au sein de la communauté en renforçant cette communication. Nous avons aussi eu, grâce à cette formation, à diffuser des messages clairs, adaptés culturellement et selon les différentes cibles. Vous savez bel et bien que moi, la Mpox a concerné une catégorie qui était stigmatisée, les professionnels des sexes. Donc, ça a permis de réduire la stigmatisation au sein de cette communauté. Aussi, les agents de santé communautaires ont sensibilisé sur l'importance des mesures barrières, des gestes barrières, l'hygiène.
Unfortunately, Dr. Pierrette, we cannot hear you very well. I'm apologize for interrupting, but we cannot hear you very
ça a
well.
aussi permis le référencement.
Dr. Pierrette, my apologies, because we cannot hear you very well, and also because we're so well over time, we'd like to thank you for joining and for speaking, but perhaps we'd like to now move on to Dr. Rim. My profuse apologies.
Thank you so much, Supriya. I'm just watching the questions coming from the floor. I think there are so many questions, very interesting questions, kind of defining the community as focus, and also the enumeration issue and payment, and also sharing this material, and also recording, all of the things. And also regarding national policies and regulation, and also for WHO partnership to really work together for this further development of these competencies, etc. So, since we don't have much time to discuss, therefore I'll just pick up two big things. One is regarding national policies and regulation, systematically engaging for community health focus. And second, about WHO plan to have more partnership for rolling out this kind of competencies and community health focus training in the context of community protection. So probably I'll give floor to Dr. Kai, the unit head for community protection region, to speak about WHO plan to have a broader partnership for community health focus training packages and competencies. Then second, to go to Dr. Dansan regarding the national policies regulation to really systematically empowering communities for disease prevention and detection response. First, Dr. Kai, over to you.
Yeah, thank you very much for this very important question. And just to highlight regarding the question you mentioned on the compensation, I think WHO has a very clear recommendation against unpaid volunteerism of community health workers, and I think there were some already some answers to that also in the Q&A. I think for sustainability issues, really community health workers require fair compensation for their work. I think that's a very clear recommendation of WHO. But coming to the question about the consultative process, I think that's a very, very important question. And of course, I think we have spoken quite a bit during this exercise already on the process we have followed so far. There's a lot of engagement. Of course, we have our key partners, IFRC and UNICEF, for the wider community protection approach, which is really collaborative by design. We do a lot of collaboration with colleagues from the surveillance side, for example, where there's a lot of important touch points around the work. And then we have key technical partners like UK Health Security Agency, and of course across the 3 levels of the organization, where we saw some very good examples. It's also very important, our collaboration with the Health Workforce Department around making sure that the work we are doing that is really specific on the emergency context is very much in line with the routine work, with the community health worker mechanisms for essential health service provision, around health workforce strengthening, etc. So that's a very, very important aspect of our work around that. And what is very important is the feedback from community health workers on the piloting we've done. We've heard some great feedback today, but we're also collecting this, of course, systematically to make sure that these tools are user-friendly and grounded in the local realities. So kind of experiences from the operational responses are very, very important. And then I mentioned that we are also shifting, of course, we followed an ad hoc training approach for these 2 like rapid onset emergencies we had, and now we are simultaneously working on a more systematic and competency-based learning approach. And for that, we had already quite a structured consultative process with, I think, 5 online workshops around the Learning for Impact series to define a competency framework for different audiences, including community health workers. And this was really just the start of the process. And this is really a multi-stakeholder process. We also engaged there, of course, our regional offices, global CHW alliances, which are very important in this context as well, and academic institutions, the RCCE and community engagement experts, but also the more senior level emergency response decision makers, because it's very important that we anchor it there as well. And of course, this is kind of a start of the process, and we plan to continue this consultative process around the competency framework, the curriculum, and then also this rollout systematically of these trainings much more intensively. Of course, we are all aware of the resource limitations we have, so we have to make use of kind of online and innovative approaches like we are doing here. And so if anybody is interested in contributing to this exercise as well, then we'll be happy to involve you and share and circulate the draft framework for the technical feedback. And we also have a broader validation and process where we will systematically reach out to those key partners that we are aware of. I hope that answers the questions, and back to you.
Thank you so much, Kai. And now I'll go to Dr. Dansan. When we were in Uganda, we saw that you are working very closely with Billy's Health team. It looks like you are a friend with all this Billy's Health team. So as National Community-Based Surveillance Coordinator sitting in Minister Affairs, I think it's really important for sustainability, having this clear policy and regulations. So what is your view, and what are the things that you can share with participants? Over to you.
Thank you so much, Dr. Rim. As Uganda, we developed what is called community health strategy that has been implemented in about 12 districts out of 46, 146 districts. Uganda has 146 so far. We have piloted in 12 districts. And what we are looking for in sustainability, we have got in the policy, we have got the remuneration, how we can facilitate the community to perform routine community-centered interventions. And one of the key things that we have factored in is some small token of appreciation together with the VHT kits. But also as a country, we have what is called community-centered intervention, where if there are outbreaks, we engage, we are delighted, and we are recommended to involve the community in the response, right from detection to notification and then response. So we are the strategy that we have developed is about 3 years old, and we are trying to roll out to the entire countryside. But so far, so good. It is giving us some good impact in the communities that we have rolled them out. Thank you.
Thank you very much. I think that's excellent experience that can be also beneficial to other countries. I think there are so many questions, but for the interest of time, we can stop here. but we can still connect with through Supriya, through this EPI-WIN platform to connect with us. And also, as Kai mentioned, that we are ready and are highly committed to further collaboration in this area. Over to you, Dr. Supriya.
Thank you so much, Dr. Rim. And a huge thanks to all the participants for being with us, even though we're terribly, terribly over time, and also for sharing all your insights over there. As Dr. Rim said, we'd love to engage with you more, but in the interest of time, please do write to us as EPI-WIN at who.int. We have we'll be sharing the email on the chat now. It's EPI-WIN at who.int. Please do write to us. I'd like to thank all our wonderful speakers and panelists today. Dr. Kai von Harbu, Dr. Rim, Dr. Claire Bentun, Dr. Atim Dansen, Miss Edith Nagula, Dr. Pierrette, who joined us very briefly, but at least we could get her perspective, and also Dr. Ruben Samuel for giving us that comprehensive overview of another region altogether. I'd like to also thank everyone who's worked in the background. Sangamitra Barua from Project ECHO, our collaborative center, Burke Gareklu, who's working in the background, our interpreters for French and English, our support from WHO virtual meetings and CMP, who've been extremely supportive. So thank you for everyone for making this webinar so interesting. I've put this in the chat, but we also have a World Health Assembly side event on 22nd May at 8 to 9 a.m. in Geneva, but you can also join online, and the details are in the chat. So please, and I've put the flyer as well in the chat. So please do join if you're interested. And I hope to see you next Wednesday for the next EPI-WIN webinar at the same time, 1 p.m. Geneva time. Next week, we will have an update on the chikungunya virus disease outbreak. It's a focus on the Indian Ocean, but we'll look at chikungunya across the world and also look at the new chikungunya vaccination and what works, what doesn't work. So look forward to seeing you next week. And thank you once again for your support, and thanks particularly to all the panelists. Really appreciate it. I'd also like to thank Dr. Catherine Kane from our health workforce team who joined us, and she's also provided some links and information in the chat. Do go to that. That will give you more information on community. And there she is. Hi, Catherine. Great to see you here, and thank you for sharing the resources in the chat. Excellent to that. Thank you very much, and see you soon. And most importantly, I forgot to say, Dr. Rim Kwon is the technical lead for this area. This webinar would not have been possible without him. So my apologies. Last for the best, or best for the last. Thank you, Dr. Rim.